All right, well, it's 4 o'clock, so if we want to go ahead and start, that's fine.
All right, so I'll quick welcome everybody to, this is the NEP Spring Summer Seminar Series. This semester, we had our graduate students were actually able to invite 3 speakers. So this is one of our graduate student weeks. So I'm gonna pass it off to Gavin for Dr. Boerman's introduction.
Hey, Dr. Boerman.
Hello.
Okay, so I'd just like to start by welcoming Dr. Erika Boerman on behalf of all the graduate students here at NEP. It's often great to have external investigators come here, but it's also really, really exciting to hear our own incredible investigators that we have on our doorstep. And I believe Dr. Boerman fits this category. So we're delighted and excited to have you. Erika Boerman is an assistant professor in the Department of Medical Pharmacology and Physiology at the University of Missouri. Prior to starting her current position, Dr. Boerman completed her undergrad at Michigan State, and also she also completed her PhD at Michigan State in pharmacology and toxicology, where she studied calcium signaling in the microcirculation. She then came to MU in 2011 as a postdoctoral fellow with Dr. Steve Siegel, where she studied the role of perivascular nerves in aging, vascular aging, that is. She transitioned to her current position upon receipt of an NIH K99 award, and her laboratory's research now centers on understanding the vascular dysfunction in inflammatory bowel diseases such as Crohn's disease and ulcerative colitis. Her current projects use pressure myography, confocal microscopy, and molecular biology to determine how macrophages impair perivascular nerve and adipose tissue function, decreasing blood flow to the intestine. The overall goal of her research is to prevent vascular inflammation and preserve vasomotor function in patients with inflammatory bowel disease in order to improve their quality of life. She has won countless awards and has a great publication record. With that being said, I think we've all heard enough of my voice, and we're excited to see what you're going to show us today. Dr. Boerman, it's all you.
All right, thank you so much, Gavin. Share my screen here. So because this is mostly a student audience, I tried to lay out my talk in a way that's somewhat chronological, especially because I am a new investigator, to kind of show you guys how I started my new area of research, my independent research, kind of just from an idea I had and then the beginning experience that have then turned into my main focus of research. So I'm trying to keep it in a fairly linear direction so you can trace the path from the end of my postdoc through the beginning of my PI years to now. So as Gavin said, my main focus is vascular dysfunction and inflammatory bowel disease, or IBD. And for those of you who aren't familiar, IBD is ulcerative colitis and Crohn's disease. UC generally is limited to the large intestine only, whereas Crohn's disease can be throughout the GI tract. Both of these diseases are complex autoimmune diseases, and they have very complicated etiologies and variable presentations, and that makes it difficult to study and understand. There's factors contributing to the prevalence that include things like genetic susceptibility and microbiome, more physiological factors, but there's also a lot of lifestyle factors like medication, sleep, diet, stress, physical activity, even strange things like whether or not you've had an appendectomy, vitamin D exposure, and the region you live in plays a big role too. But regardless of which disease you have and the severity of your disease, the undercurrent for everybody is a chronic immune response coupled with GI inflammation. And one of the reasons that I think we should all care about this is that it currently affects about 1.3% of the US population, but it's rapidly rising. So you can see here that this paper is a little bit old now, it was in 2008, but IBD is expected to essentially double in prevalence by 2030. And that's despite the introduction of monoclonal antibody drugs such as Humira and other anti-TNF therapies. So there's other ways we need to look at this besides the things we're currently focused on with IBD. And as I said, despite these treatments, IBD deaths have actually increased 70% since 1990. One of the things that was both surprising and interesting to me is that people with IBD are also much more likely to have cardiovascular diseases. And that includes embolism, atherosclerosis, stroke, heart attack, ischemia, and other cerebrovascular diseases. And what's most fascinating to me, is that you're more likely to have those cardiovascular diseases despite that IBD population having a low risk, lower traditional risk factors such as, increased body weight, diabetes prevalence, blood pressure, and cholesterol levels. So something different is going on with these patients that makes them more at risk for cardiovascular diseases. And coming from my background, doing vascular studies, I naturally wondered what is happening to the vascular function with IBD. So as Gavin mentioned, I have been focusing my research since my postdoctoral time on perivascular nerves, first in aging and now in IBD. I think they're extremely important, and the literature bears out that they're very important to the mobilization of blood flow in and out of different tissues. So most vascular beds are richly innervated. I showed a picture here. This is a mesenteric artery similar to the ones I'm going to be talking about in the rest of my studies here. This is stained for PGP 9.5, which shows all types of perivascular nerves. And these are out in the adventitia of the blood vessels. And depending on where you are in the body, you have sympathetic sensory nerves, parasympathetic, and nitrogic nerves. And there's also some other nerve types as well. But for the purpose of today's talk, we're only going to focus on sympathetic nerves and sensory nerves, with the primary focus being sensory nerves. So this is an extremely simplified schematic just to show you the very basics of how these things work. So if you look up in the adventitia where the nerves reside, if you activate sympathetic nerves, the main transmitter released is norepinephrine, which then binds downstream to adrenergic receptors on smooth muscle cells, causing sympathetic vasoconstriction. On the other hand, if you activate sensory nerves, the primary transmitters released are calcitonin gene-related peptide, or CGRP, and substance P. And CGRP will bind to its receptors on both smooth muscles and endothelial cells, whereas substance P binds to neurokinin receptors only on endothelial cells, and both of them lead to sensory vasodilation. And looking through the literature, it's evident that there's perivascular nerve dysfunction in many cardiovascular conditions, as well as outside of cardiovascular conditions. And what I'm interested in looking at is whether this is also true in inflammatory bowel disease. So before I get into some of my studies, I just kind of wanted to point out a bigger picture view. So everything I'm going to talk about today was done in isolated mesenteric arteries like these you see here in the mouse mesentery that's pinned out in a dish. And I think it's important to point out that with inflammatory bowel disease, decreased blood flow to the intestine is characteristic. And in fact, it's used as a diagnostic tool. So that was one of the reasons that I was really interested in studying some sympathetic and sensory nerves, particularly sensory nerves, which are responsible for dilating vessels and allowing more blood into the gut. But in addition to just perfusing the gut, if you follow these nerves and blood vessels down, they actually continue directly into the wall of the intestines, both the nerves and the blood vessels, and can contribute to physiological functions there. So beyond what I'm going to talk about today, there's also implications directly for the function of the gut here. So we know that with IBD, you have decreased GI blood flow. And just on kind of a whole body level, we know that CGRP and substance P can modulate pain and GI motility. Based on my work and many other people's work, we know that CGRP and substance P can modulate blood flow and vasomotor function through their actions in the blood vessel wall, in the adipose, adventitia, and then downstream in the smooth muscle and endothelial cells. And perhaps most relevant to IBD is that CGRP and substance P are both potent modulators of immune responses and inflammation in the body. So we actually know something about how these transmitters work on a whole body level in IBD. So CGRP is anti-inflammatory in IBD patients, and patients with high CGRP levels tend to have decreased disease severity, whereas the inverse is true for substance P. That tends to be more pro-inflammatory, and high substance P levels are linked to worsening disease. And the way I think of this is it essentially kind of tips the balance on this scale. So substance P pushes you down towards a more pro-inflammatory state, whereas CGRP can push you down to a more anti-inflammatory state. And in an ideal world, you're in balance. So the first studies I wanted to look at were just to define whether there is sensory nerve dysfunction in IBD. And to do that, we first needed to select a mouse model. And this is one of the most important things that you can do when you're deciding to start new studies of a disease. And there's many, many, many models, hundreds actually, that people have used to study models of inflammatory bowel disease in mice and other animals. This includes chemically induced models, microbiome induced, T-cell transfer models, quite a few genetically engineered models, and some with spontaneous mutations. We settled on the IL-10 knockout plus Helicobacter hepaticus model. This combines the microbiome-induced and genetically engineered approaches to study the disease. So for those of you who aren't familiar, IL-10 is a pluripotent anti-inflammatory cytokine, and thus when you knock it out in this mouse model, it kind of primes the system to a pro-inflammatory state. However, the mice lacking IL-10 do not get colitis by default. It requires association with Helicobacter hepaticus, which we use, or other microbiome triggers to cause IBD. So the studies I'm going to talk about in the first part of this, we use male and female mice, and after weaning, the mice receive 2 doses of Helicobacter via oral gavage or sham controls, and then they develop disease for 90 days before we begin experiments. So these are all the studies of what I would consider established IBD. It's allowed to develop for a significant period of time. And one of the things that I think is important to point out, because IL-10 is so important in regulating immune and inflammation, is that all of the mice are lacking IL-10. So the changes we're seeing between the groups are not just because of the lack of IL-10, but because of the induction of the IBD. So the first things we wanted to do are look at the ability of sensory nerves to inhibit sympathetic constriction. And the way we did that was looking at pressure myography, which is a technique we commonly use in the lab. So you can see a cannulated mesenteric artery here in the neighborhood of 200 microns in diameter. And then we couple that with electrical field stimulation, which is just 2 platinum electrodes placed around the vessel chamber that produce an electrical stimulus to activate those nerves outside of the body. So because there's not much myogenic tone in these vessels, and sympathetic nerves are very, very predominant over sensory nerves in mesenteric and most other arteries, if you just stimulate everything, what you're always going to see is vasoconstriction. So the first experiments we did, we just stimulated over a range of frequencies and measured the resulting constriction. And as you can see, the control in black, there was significant frequency-dependent constriction, as you would expect. A similar result with a little bit less constriction at higher stimulation frequencies for IBD. So this suggests that there might be a little bit of impairment in sympathetic vasodilation. Then we repeated this same experiment after treating the vessels with capsaicin, which blocks the role of the sensory nerves. So once we do that, if we stimulate again, instead of stimulating all nerves, we're only stimulating the sympathetic nerves. And when we do that, you can see in the 2 sets of black lines, you actually get more constriction after capsaicin treatment because you remove that inhibition from the sensory nerves. They're no longer counterbalancing. And the difference between these 2 lines kind of shows you the degree of sympathetic inhibition that's present. And by contrast, the plus and minus capsaicin lines in IBD group is basically superimposable, which suggests that there is no sensory inhibition of sympathetic vasoconstriction in the IBD model. The next thing we did was using a similar technique, but we wanted to look directly at vasodilation instead of just the ability to inhibit vasoconstriction. And these were a little bit trickier. As I said, these vessels don't have much myogenic tone, and the sympathetic nerves do tend to predominate. So in order to study vasodilation directly, you first have to pre-constrict the arteries with phenylephrine and then block sympathetic nerves with guanethidine. And after we do these 2 treatments, then stimulation with the electrodes allows you to look at sensory vasodilation. So here we're looking at percent dilation rather than constriction in the previous figure. And I'm showing just 8 and 16 hertz for clarity. So if you look at the black, this is the control mice. You have a robust vasodilation, frequency dependent, and that's significantly attenuated in the IBD mice, which shows that in addition to poor sympathetic inhibition, you also have very little ability of these nerves to dilate to sensory stimulation. So this is consistent with impaired blood flow to the gut in IBD and possibly a role for these sensory nerves. So now that we know that there is sensory vasodilation, we needed to move on to kind of looking at why that happens from as many angles as we could. And the first and most obvious experiment was to look at the nerves themselves. Is there more sympathetic nerves, more sensory nerves, less of each? And to do this, we did immunofluorescence experiments and confocal microscopy. We labeled sensory nerves with both CGRP and substance P, and we labeled the sympathetic nerves with tyrosine hydroxylase, which is the rate-limiting enzyme to produce norepinephrine. And you can see on the top, there's fairly robust staining for both CGRP and substance P in control and IBD vessels. This is just an overlay of the two on the right. And then below, there's quite a bit of staining for sympathetic nerves as well. And I think comparing these two really shows how predominant the sympathetic nerves are compared to the sensory nerves in these vessels. We also went on to quantify this data and looking at the percent area of the vessel that's occupied by each nerve type, you can see that there's no difference in CGRP positive staining, a slight but significant increase in substance P positive nerves, and a significant decrease in sympathetic nerves. And this is basically the opposite of what we expected. We thought that there would be significantly decreased sensory nerves and increased sympathetic nerves. So this was a bit of a surprise that functionally, even though the sensory nerves are preserved and the sympathetic nerves are decreased, that they're still unable to overcome that barrier and cause vasodilation. So it seems like the nerve density is not a good indicator or isn't related to the impaired sensory vasodilation. So next we moved on to looking at whether there was a difference in the content or the release of the neurotransmitters from sensory nerves. And to do that, we used ELISA measurements. So to measure the content within the vessels, we just collected as many mesenteric arteries as we could, and then measured the CGRP and substance P control and IBD groups in the homogenate. And so you can see for both CGRP here on the left and substance P on the right, there's a trend, a non-significant trend towards a decrease in content of neurotransmitter in these vessels. And this is exactly what we found when we measured the release as well. So to measure the release, we cannulated and pressurized these vessels just like the functional experiments I showed before. We stimulated them maximally for a minute and then collected the bath solution and measured the content of CGRP and substance P in that bath solution. So while these didn't reach statistical significance, it suggests that maybe it's playing a role, the decreased release of transmitter in the inability to produce sensory vasodilation with IBD. We also wanted to look more directly at receptor function and expression. So when we do our pressure myography and electrical field stimulation experiments, you stimulate them and you're just looking at what happens based on the release of the transmitter from those vessels, however much is coming out that you don't really know. And we wanted to see whether these receptors are functional when we're providing exogenous transmitters. So what we did is concentration response curves to both CGRP and substance P. So for both, we're looking at transmitter concentration on the X and percent max dilation on the Y. You can see looking at CGRP that there's not much difference, maybe a slight trend towards decreased vasodilation in the IBD group. Whereas looking at substance P, you get a fairly robust concentration dependent dilation in the control group that's significantly attenuated with IBD. So substance P and CGRP seem to be having different effects here, with receptor function uniquely impaired in the substance P side, which if you recall is our pro-inflammatory transmitter based on literature. So in addition to measuring receptor function with concentration response curves, we also measured the expression using confocal microscopy. I'm not showing the smooth muscle cell staining because we saw no differences in either transmitter between control and IBD. But this is the endothelial cell staining. So we used RAMP1 protein, which is one of the important proteins in a CGRP receptor. And then NK1 is neurokinin 1, which is the substance P receptor. And we have control on the top, IBD on the bottom. And you can see that for RAMP1, there's not much difference between the control and IBD. Whereas looking at the NK1, there appears to be a significant increase in receptor expression. And we haven't quantified this data yet, but we do plan to do that. So it does look like there's some receptor dysfunction, as well as decreases, or as well as changes in receptor expression, possibly upregulation due to the decreased transmitter release, but that's mostly speculation on my part. So we also wanted to look at the relative contribution of CGRP and substance P to sensory vasodilation. So I had that idea that I showed before that maybe in IBD you have kind of a tipping of the scales to a more substance P-like phenotype and less of a CGRP-like phenotype. So we wanted to see functionally if it seems like more of the dilation is due to CGRP versus substance P or vice versa. So to do this, we first pre-constricted and blocked sympathetic nerves, just as we did in the previous experiments that I described. And then sequentially, we used BIBN 4096 to block CGRP receptors and CP9994 to block the NK1 receptors. And this data is a little bit complicated, so I'm only showing a 16 hertz, which is our maximal stimulation frequency, but the trend held across all stimulation frequencies. So if you look in the control group, we have a robust vasodilation under control conditions, which is what we saw before. When we apply our BIBN to block CGRP receptors, you block the majority of that vasodilation. And then when you add substance P receptor blockade on top, you block more of the vasodilation, which is to a certain extent what we expected in these experiments. And when we reverse the order, we did this just as an important experimental control to make sure that there's not an order effect of the two antagonists we used. We basically just got the opposite effect. So our dilation was partially blocked by CP, and then the vast majority was blocked when you block the CGRP receptors. So that's all in the control mice. Then we repeated in the IBD mice. And you can see that as before, compared to control mice, you have a significantly attenuated vasodilation under control conditions. And a little bit of that is blocked when you block the CGRP receptors, with a little bit more blocked with substance P receptors. And I should also mention a lot of these combinations did reach statistical significance, but I took out the indicators just to clarify the figure for you guys. What was extremely surprising to us is what we found when we reversed the order. So unlike the control experiments, where we saw basically the same thing in reverse, here we saw our decreased vasodilation, just like in our previous experiments. But when we blocked our NK1 receptors, our substance P receptors, we actually got an increase in vasodilation. So blocking the substance P receptors seemed to kind of fix the problem of vasodilation in the IBD group. And then when we added CGRP receptor blockade on top of that, you block the majority of vasodilation, as in the previous experiment. So this looks like kind of a weird situation where we have substance P inhibiting CGRP vasodilation. And to confirm that, we did some additional concentration response curves in the presence of these blockers. And I won't spend much time on this in the interest of time, but in the control group, everything acted like it should. The substance P receptor antagonist blocked substance P vasodilation, CGRP antagonist blocked CGRP vasodilation in the control mice. The same was true for substance P in the IBD mice. The NK1 antagonist blocked the vasodilation to substance P. And then most importantly, we confirmed that strange phenomenon that we saw before. When we did our CGRP concentration response curve, this is our control curve here in the middle, where you see our concentration-dependent vasodilation. And then that's mostly blocked in the presence of the CGRP receptor antagonist, as you would expect. And in the presence of the substance P receptor antagonist here in the triangles, you see an increase in vasodilation. So that actually made me feel a little bit better that this phenomenon we were seeing in our electrical field simulation experiments wasn't just some sort of experimental fluke. So this kind of verifies that something unusual is happening with substance P signaling that appears to be interfering with CGRP-mediated vasodilation during IBD. So just to summarize what we've seen so far, we didn't find significant changes in CGRP nerve density. We did see increases in substance P nerve density. We found decreases across the board in content and release of sensory neurotransmitters. CGRP receptor function and expression appears to be preserved, whereas NK1 receptor expression is increased despite decreased sensory vasodilation. And then we also have this strange new phenomenon where activation, where if you block the NK1 receptor, you get a strange inhibition of this pathway coming through CGRP receptor activation. And that's something we want to explore more in the future. So moving on to part two, a little bit of a 180 from what I was talking about before, that this is probably the project I'm most excited about now, which is adventitional macrophages in IBD. So in parallel with all of those previous experiments that I was doing, we had also collected intact mesenteric arteries from control and IBD mice and sent them out for RNA sequencing to just kind of serve as an index of, you know, where we might want to look in the future for interesting changes. And I expected to see a lot of ion channel changes, mostly because that's the background I'm coming from. And what I was surprised to find, although in retrospect it makes a lot of sense, is that the genes that were most upregulated in mesenteric arteries with IBD were those related to macrophages and other immune cells. So this is 10 genes out of the top 30 that I'm showing here that are macrophage-related genes with increased expression in mesenteric arteries from IBD versus control. And you can see a lot of common markers such as MIP1 alpha, CD163, which is an M2 macrophage marker, CD68, MAC1, F480, and CD206. And there were many, many others in the 226 differentially expressed genes that came up in this study. And if you look at the pathways that are enriched based on the gene expression changes, they're all regulated, they're all related to inflammation, leukocyte migration, and immune cell related changes. And obviously this makes sense if you think of it. I don't know why I expected something a little bit different, but it is an autoimmune disease, and it makes a lot of sense that that would be the sorts of changes that you're seeing even within the blood vessel wall. So this is the direction we decided to pursue for the next phase of our research. And the two big questions we wanted to answer are, do macrophages accumulate in the adventitia with IBD? And does getting rid of those macrophages do anything to change perivascular nerve function in the disease? And to do this, we used macrophage depletion with claudronate liposomes. So these are just lipid liposomes that contain claudronate. And then when phagocytosed by macrophages, it causes apoptosis and kills the macrophages, not just in the blood vessels, but throughout the body. And we just kind of piggyback this on top of our standard protocol. So after our 90-day disease development, both the control and the IBD groups have received an injection of PBS-containing liposomes, which basically does nothing, and then half received injections of the claudronate-containing liposomes. So we have 4 groups: controls with and without macrophages, and IBDs with and without macrophages. And the first thing we wanted to do is some more immunostaining experiments to just look at the presence of immune cells in the adventitia of these blood vessels and whether it is successfully altered by claudronate treatment. So this is a claudronate or a PBS liposome control. And I think most of you are familiar with JAPI. That's a nuclear stain. We labeled CD45, which will label all hematopoietic lineage immune cells. CD68 is a macrophage marker in mice. And PGP 9.5 labels all perivascular nerves, not just sensory, but sympathetic and others as well. And then on the bottom is just the merge of all these channels. So you can see in the control mice, there's a small amount of immune cells in the adventitia. Some of the CD45 positive cells are also stained for CD68, suggesting that they're macrophages. Some of them, like this one, are not. So you have macrophages and non-macrophages in the adventitia of these control vessels. In contrast, when we looked at an IBD mouse injected with PBS liposomes, we saw a big increase in the presence of both CD45 positive and CD68 positive immune cells, both in terms of number and just the size and complexity of these cells. And as you can see, most of the cells that are stained in CD45 also appear to be stained with CD68. So most of these immune cells appear to be macrophages. And then when we treat either control or IBD mice with the clodronate containing liposomes, this is just an overlay of all the channels. You can see that our green is completely wiped away. So there's no macrophages left, maybe a few little remnants here. And then there's some CD45 staining remaining, and that's our non-macrophage immune cells. So that's actually a good thing to see, which is that it didn't eliminate our non-macrophage immune cells in the wall. So we know that the clodronate treatment is effective. We also repeated the experiment staining for MHC2, which stains all antigen-presenting cells. This is the control PBS liposomes, so essentially control. And you can see that there's, again, some cells present in the adventitia. And then same for CD163. Unfortunately, no matter how many antibodies we tried, CD163 always seemed to also stain the perivascular nerves, which was disappointing because this was one of our big hits on our RNA-seq. So we really wanted to try and make it work, but that was just an experimental limitation that we ran into. You can see that, like what we saw on the previous slide, MHC2 positive cells are greatly increased in the IBD group with the PBS liposomes. Many of these cells are also positive for CD163, suggesting that they're macrophages. And then clodronate gets rid of the majority of MHC2 positive cells, which is why you see no red. And then we're still seeing some of that non-specific nerve staining. So I think we're probably going to abandon these CD163 antibodies because there's just too much non-specific staining. We went and hand counted all of the immune cells in all of these images to quantify our cell changes in all 4 groups. So if you look at black is the control group. From black to gold, we have a significant increase in CD45 positive cells. And in both groups, it's significantly attenuated by clodronate treatment. And that's the exact same trend we found with MHC2 positive cells, CD68 positive cells, and CD163 positive cells. So it seems like that directly answers our first question, which is, yes, there is an increase in macrophages in the adventitia during IBD. And we know we can deplete those with clodronate. I should also note that we quantified our PGP 9.5 staining, and the clodronate does not appear to have any effect on nerve density, which is good. So we didn't have to worry about that in our functional experiments. So we were excited about that, but obviously the big question is whether depleting these macrophages means anything in terms of the function of the sensory nerves. That was kind of the big question. So to do that, we looked at all 4 groups of our mice again, and first looked at the ability of the sensory nerves to inhibit sympathetic constriction, just as I described in previous experiments. So we first stimulated across our frequencies under control conditions, and then afterwards with capsaicin. So starting with the control PBS mice, we have significant frequency dependent constriction, just as we saw in the other studies, with an increase following capsaicin treatment. And this difference again is our level of sympathetic inhibition. When we repeat that in the IBD PBS group, we saw the same thing we saw before, which is attenuated sympathetic vasoconstriction. I showed in the dotted line here what the max constriction was from control. So you can see we're significantly below that in our IBD group. And just as we saw before, capsaicin doesn't appear to do anything to change that. So we have a lack of sympathetic inhibition. In our clodronate control group, you can see that we actually saw a bit of a decrease in sympathetic vasoconstriction. So this is the level we reached before, and after clodronate treatment, it actually seems to have decreased sympathetic vasoconstriction somewhat. Although after capsaicin treatment, you still see some separation between those curves, so that you can tell that the sympathetic inhibition appears to be preserved following cladribine treatment in the controls. But what we were really excited about was the experiments for the IBD cladribine group. So you can see in the PSS group that instead of essentially having little to no vasodilation, which is what we saw before, or vasoconstriction across many of the frequencies like we saw here, you restore some of that back towards control levels. And we were excited to see a little bit of restoration of function there. And you get an increase in vasoconstriction with capsaicin once you get rid of the macrophages. So the cladribine appears to have restored some of that sympathetic inhibition by sensory nerves. Now we can see the distance between here. So this was our first piece of evidence that functionally it seems like macrophages might be interfering with sensory nerve function with IBD. We next did our more direct experiment to look at sensory vasodilation directly. And again, we did the experiment exactly like I described before. First pre-constrict our arteries, block sympathetic nerves, and then do our electrical field stimulation to look at vasodilation. And in the PBS groups, we saw the same thing we've seen before. So significant frequency dependent dilation and controls that significantly attenuated in the IBD group. But amazingly, when we looked at the cladribine group, we saw almost a complete restoration of function in the IBD group. So if you look at the controls first here, they're essentially superimposable. So the function remained preserved with no impairments in the control group, and that was positive to see. But most importantly, you can see that after cladribine treatment, you get restoration of the sensory vasodilation essentially back to control levels. So I was super excited about this, and this is an area that we're going to pursue much more heavily. So to summarize that piece, macrophages, both CD68 positive and CD163 positive, antigen presenting cells and our leukocytes appear to accumulate in the MA adventitia during IBD. And macrophage depletion with cladribine restores our IBD impaired sympathetic constriction and sensory vasodilation without altering perivascular nerve density. So I want to leave plenty of time for questions, but I just want to show you one piece of bonus data. That's another thing I'm very excited about for future directions, which is looking at the role of the perivascular adipose tissue. So as a person who studies what I call outside-in regulation of vascular function, so rather than endothelial and blood-derived substances moving inward out, we're looking at changes happening out here in the adventitia or perivascular adipose tissue and working inward. And almost all the experiments, in fact, all of the experiments that I showed today were done in isolated mesenteric arteries where we just cut the fat off. And so we didn't have any idea what the fat was doing in terms of regulating function. But anatomically, you can see that the perivascular nerves that are so dense in the adventitia are continuous with the perivascular adipose tissue. And similarly, the immune cells that populate the adventitia are also there out in the perivascular adipose tissue. So it makes sense to look at what's happening with the presence versus absence of PVAT. PVAT is kind of having its moment right now in terms of being considered an actual functional layer of blood vessels versus just an inert tissue that's on the outside. So to do these experiments, we just measured electrical field stimulation responses in the presence and absence of perivascular adipose tissue. This picture just shows what it looks like when we set up the experiment with the perivascular adipose. So we just leave everything attached and then we cut out a little window, and this is how we measure the diameter of the vessel. And so in control vessels or control mice, you can see that without PVAT in the dotted lines, which is similar to everything I've showed up to this point, you have, again, a robust frequency dependent vasoconstriction, and that actually goes down a little bit in the presence of PVAT. So that suggests that in healthy conditions, PVAT is anti-contractile. And that's very consistent with what has been shown in other healthy blood vessels across a number of vascular beds and labs over the past 10, 15 years. But when we repeated the experiment in the IBD group, we found that looking at the plus PVAT group, you actually get an increase in vasoconstriction in the presence of PVAT compared to what we saw under our normal conditions where we have removed the PVAT. So that suggests that during IBD, the PVAT shifts from an anti-contractile to a pro-contractile phenotype. And that might really contribute to a lot of the things we're seeing before, and explain some of the reasons why changes in nerve density might not necessarily contribute to the phenomenon we're seeing functionally. So this is an area we're very excited about in the future. And just to kind of summarize where we're at now and where I see the lab going in the future, what we've noticed in measuring the perivascular adipose is that it appears that there's less of it with IBD, and yet there's more macrophages contained in the PVAT layer, just as we saw in the adventitia. And it appears that that macrophage infiltration, both in the nerve, around the nerves and around the PVAT, appears to inhibit vasodilatory pathways and increase sympathetic vasoconstriction. And what that does is kind of push the whole system into a vasoconstriction state and lead to decreased GI blood flow. And so moving forward, some of the things we want to look at to better define the mechanisms of these changes is, one, to look at the timeline of vascular dysfunction. So as I said, everything we've done to this point has been in established IBD. So we don't really know at what point macrophages start to infiltrate, where they're coming from. Are they coming from out here in our intestinal area and working our way into adipose tissue and then into the adventitia? Is it resident immune cells that are populating and proliferating? Or is it immune cells coming in from a circulating source? So we don't know the answer to any of those questions, and we want to look where they're coming from and how that changes throughout the time course of IBD development. We also want to know how nerves and PVAT drive macrophage accumulation. And the way we want to do those studies is in terms of nerves, the role of nerves driving macrophage accumulation. We want to do some denervation studies, so you can use capsaicin injection to denervate the mice of sensory nerves, perivascular sensory nerves, and see if that prevents macrophage accumulation and sensory dysfunction and vasodilatory dysfunction. And then you can also breed transgenic mice that lack perivascular adipose, and that's a little bit of a more complicated experiment, but we would like to look at PVAT-less mice and see how that plays out throughout the progression of IBD. And then finally, we want to see how macrophages interfere with perivascular nerve function. And my favorite theory at this point is that because we see macrophages so closely opposed to perivascular nerves, I think that transmitter released from these sensory nerves is more likely to bind to receptors on these immune cells than it is to go downstream and bind to its intended receptors here in the smooth muscle and endothelial cells. And that'll require taking a step back and doing some cell culture experiments, vessel culture experiments, and a lot more imaging. So we'd like to get a little bit more mechanistic. I think that's important for maintaining funding and the rigor of the experiment. So those are the ideas I have moving forward. And then I just want to thank some of the members of my lab. Liz Gruns-Boerman is a superstar lab manager. She really does everything. Ben Jones is a very talented IMSD undergraduate who's got his choice of medical schools to go to for next fall. Sammy Jenkins is a master's student in the lab. The bioinformatics team was critical. I never could have analyzed the RNA sequencing data myself, so they helped with that. And then the MU flow cytometry core and the MU MARC IMSD program for funding Ben's work. And then of course my department, MPP, and the NHLBI for continued funding of my projects, really all the way from grad school up until the present time. So I wanted to leave plenty of time for questions, which I did. It's 4:45, so let's stop here, and I'd love to take some questions from you guys. Anything about research, life, anything you have for me.
Okay, Dr. Boerman, what I'm going to do is I'm going to read out the questions that some people have posted in the chat.
Okay.
So the first question comes from Dr. Lindberg, and she asks, are these all male animals? And does IBD or its cardiovascular complications occur more in men or women?
So we did all of our studies in male and female mice because IBD happens in male and female humans. And I think that it's important moving forward to, just as the NIH directs, use both genders in our studies. In terms of what we see in mice and in humans, it appears that females are a little bit more susceptible, both to getting IBD and having more severe disease, but it's not a significant effect. If you look at, we confirm I haven't shown any of the histology that we do, but after we do our functional studies, we send the guts out for histology to see how severe their disease was. And we get numerical disease scores for all of those mice. And we haven't seen any significant differences in disease scores between male and female mice, nor have we seen significant differences in our studies across male and female mice.
She also goes on to ask, do these occur at different stages of the condition, or are the impairments you see occurring early in the disease?
So this is a question that we can't answer right now because everything we've done to this point has been in established IBD in mice that have had the disease for 3 months, which is quite a bit of time in mouse world. In our current proposed work, which fingers crossed pending council review is going to be funded soon, we're going to look at some different time points. So we want to look at some of these phenomenon at, I think we picked 5, 10, 20, 40, and then we want to go out to even 180 days and see whether this macrophage related changes and sensory dysfunction is something that happens early or if it takes time to progress, and what the phenomenon is there. But the answer is we don't know at this point.
Cool. Dusty Shea asks, does having one gut autoimmune disease increase the risk for others, such as Crohn's?
So you can't have Crohn's and ulcerative colitis. Not technically.
She mentioned celiac. I forgot to point.
Celiac disease.
Yeah.
Celiac disease is independent. Certainly, if you have Crohn's or ulcerative colitis, you're more likely to have a different autoimmune disease. So those patients are a lot more likely to have rheumatoid arthritis or psoriasis and a number of other autoimmune conditions. But it doesn't necessarily make you more likely to have any other gut condition. It doesn't make you more likely to have irritable bowel syndrome. You are at an increased risk for colon cancer just because of the prolonged inflammation in the gut. But the answer is not necessarily.
Okay, great. Dr. Padilla asks, have you examined smooth muscle cell function in your model of IBD using SNP, for example, and also is endothelial cell function impaired in this model?
So to the first question, I should have actually said this more explicitly, but when we do all of our functional experiments, we end with a 0 calcium and SNP treatment to establish what the maximum vasodilation is. And we also did quite a bit of studies looking at sort of the mechanics of the vessel wall to make sure that the lack of vasodilation isn't due to remodeling. So the wall thickness, things like that, cross-sectional area, elasticity, those all remain the same across disease. So it's not remodeling, and it doesn't appear that it's because of an inability to vasodilate. There's a slight decrease in acetylcholine vasodilation, a little bit of a shift of the curve, but it's pretty minimal. So I think there is some endothelial dysfunction, but not enough to explain what we've seen before. And there's actually some groups, David Gutterman's group has done a lot of work on endothelial cell function in a couple IBD models and has shown some good things there. And smooth muscle cell function, I think that other than doing our controls with SNP and then obviously looking at our electrical field stimulation experiments and whatnot, we haven't done a lot more characterization. We've moved on to doing some high K controls in all of our functional studies, just as an index of what's the maximum vasoconstriction we can get, but we didn't actually include that control in our studies that I presented today, so I didn't discuss that. But I think that there's a lot more work to be done, and if anybody ever wanted to take on the calcium imaging aspect to that, I'm sure there would be something there, but I don't want to be that person.
Dr. Lemberg asks if some of these conditions have skip lesions. When you harvest vessels, does the location of the vessel matter?
So everything that we have looked at to this point has been in the terminal ileum, and that's because our model is essentially a model of Crohn's disease, which means that there's some small intestinal involvement. Depending on what your model is, you probably wouldn't see small intestine involvement in all of them, but we haven't gone and tested vessels further up the small intestine tract to see if you start to lose that phenomenon as you go up. We've repeated some of these experiments in essentially, so all of the vessels we look at are branches off of the superior mesenteric artery that perfuses the small intestine, but we've also done some of the experiments in branches off of the inferior mesenteric artery that perfuses the large intestine, and we found basically the same thing. It wasn't any worse as you got into the more into the hindgut as it was in the terminal ileum. So we've just kind of decided on using that moving forward, largely for logistical reasons, because to do these functional studies, you need an area where you have long enough unbranched segments that you can cannulate the vessels. And so that's what we've done, but we haven't noticed a difference. I think that if you started sampling far up the small intestine, you'd possibly lose the effect, but I can't say that for certain because we haven't tried.
Okay, another one from Dr. Padilla. He asks, he suggests that, he says, both perivascular nerve, perivascular sensory nerve dysfunction and macrophage infiltration could both lead to vascular dysfunction. In IBD, what comes first, the nerve dysfunction or macrophage infiltration?
Yeah, so that's, we don't know is the answer, but that's essentially the first aim of the grant that we have in right now that fingers crossed is going to get funded this cycle. I suspect that macrophage infiltration precedes sensory nerve dysfunction. I can't say that with certainty, but I have a strong feeling that in general, when you look at this vascular dysfunction in IBD, you have kind of a cause and effect conundrum. You know, is vascular dysfunction causing the IBD, or is the IBD causing the vascular dysfunction? And I think really what you have is just a feed forward loop where probably the IBD initiates the effects, and then you get vascular dysfunction that just feeds forward and causes more GI inflammation. So those are questions we want to answer in the next, 3 to 5 years.
He also asks, given that obesity is associated with perivascular nerve dysfunction, does obesity recapitulate your model of IBD?
So there is surprisingly a lot of similarities between observations in obesity and observations that we've made in IBD, which is interesting because if anything, both in the mice and in humans, this is a patient group that tends to be thin. Weight loss is associated with IBD. But I think that in terms of mechanisms of vascular dysfunction, there does appear to be a lot of parallels. And there also appears to be a lot of parallels in terms of the role of macrophages in sort of preventing, causing inflammation. We see a lot of parallels with atherosclerosis as well. And it's harder to draw comparisons there because so much of the work in atherosclerosis is done in the aorta, which isn't a resistance vessel. But we've seen a lot of work in obesity that's quite similar. So I do think there's certainly pathways in common there.
Okay, cool. So one of our grad students, Dane, asked, although these measurements were taken ex vivo, do you think the inflammation impaired blood flow is amplified in vivo due to altered gut-brain axis messaging, i.e. systemic elevated sympathetic activity coupled with local GI inflammation, creating a positive feedback loop?
So that's certainly possible. Once you're getting into true neural control, that's a little bit above my pay grade, but I think that's definitely possible. And just as with the earlier question, looking at some in vivo studies is an important part of our upcoming grant application. So I actually came to MU to learn how to do intervital microscopy, and Steve Siegel and I developed an intervital preparation to study mesenteric arteries, and we'd like to do that heavily in this model. Because to this point, we've made a lot of assumptions about what these things mean towards blood flow, but we haven't actually made any blood flow measurements. So one of the things we want to do is some laser speckle contrast imaging, both of the mesenteric arteries themselves and of the gut wall in different conditions and with electrical field stimulation, pharmacological treatments, to see if these conditions really are changing blood flow in the way we think they are. So I think that in vivo, if anything, probably you'll see exaggerated dysfunction, kind of as you suggested, Dane, but we haven't actually done those experiments yet. But as I showed in the beginning, because those vessels and the nerves do feed directly into the gut wall, I expect that you would see a lot of changes downstream in the gut.
I know I'm throwing a lot of questions at you, but I've only 2 left.
All right.
The next one comes from another grad student, James Ticknell. He asks, have you ever considered looking at organ crosstalk? For example, the liver can also become inflamed during IBD, and resident macrophage Kupffer cells can become activated. Could the co-activation of macrophages in these other inflamed organs impact the nerve density?
I'm not sure if it would impact the nerve density. I do think that what we see in the vasculature is hardly an isolated event. These are whole body diseases that are accompanied by whole body inflammation. And so I think it would stand to reason that if you looked at almost any organ, you would see changes in immune cell amounts and distributions. One of the things we want to focus more on in the future is, instead of just looking at total macrophages, looking at macrophage phenotype. So on the sliding scale of pro-inflammatory, more M1-like, to anti-inflammatory, M2-like, we want to see where we're existing on that spectrum as the disease develops. And we also want to look at some of the phenotypes of some markers of the macrophages to see if maybe it's coming from the peritoneal space, or some of the more complicated marker schemes that accompany looking at resident macrophage populations in the adventitia. And right now we're working on kind of the technical side of that, because that requires flow cytometry measurements, and it's a real challenge to dissociate enough blood vessels that you can get enough macrophage population to put through the flow cytometer. And we're not quite there yet, but we're working on it. And that's another thing that's written into our next grant. So hopefully we'll make a technical breakthrough soon. That's all on my technician, Liz, and she'll be the one to do it.
Okay, Talia asks, do current drug treatments for IBD reduce macrophage infiltration in the intestines and their perivascular nervous systems? Or does this line of research open the door for potentially new drug treatments to address these dysfunctions?
So nobody has looked at the effect of current IBD drugs on perivascular nerves, because nobody else is really looking at perivascular nerves, period, in IBD. We do know that some of the vascular impairments, and especially blood flow, improves on things like anti-TNF therapies, alongside improvements in macrophage populations. Nobody is really looking in the adventitia of blood vessels, but in the gut wall itself, the anti-TNF therapies do cause a decrease in macrophage populations. So I think that those treatments probably would be helpful, and that's something we would like to do in the future, but I'm not totally sure. What was the other part? I have already forgotten the second part of the question.
She was just wondering if this opens a line of research for new drug treatments.
Yeah, I certainly think it does. I think that because the disease is so multifaceted, any new avenue for treatment is a good one. And I also come from an aging background, and one thing that we really need to consider in the future of treating IBD is the aging population. And these anti-TNF drugs and the monoclonal antibody drugs are not really meant to be used long-term, and 2, they're not tolerated very well by older populations, and can cause, immune deficiencies and even cancers like leukemia. And so I think if you can develop treatments that target something different, like the blood vessels, that might help just like these other therapies, you might not cure the disease, but you can greatly improve blood flow to the gut, which decreases pain, increases quality of life, and that can just help manage the condition. So I think that would be certainly an ideal solution in the future, is to develop something that could target, maybe the substance P receptors based on our data, or the sensory nerves directly as a treatment.
Okay, a couple more questions have come in if we have time. So
I have time if you have time.
okay. Dr. Elizabeth Parks asks, what is the purpose or benefit of dilation of vessels due to sensory stimulation? Is this to facilitate absorption of nutrients into the blood?
Yeah, so if you look at, I'm sure all of you have seen in textbooks, the percentage of blood flow, the percentage of cardiac output that goes to different systems in the body under resting and exercise conditions. So if you look at rest, you have about 30% of blood flow going to your GI tract. And, if somebody put a gun in your face and you had to run, you need to mobilize all of that blood out of your gut immediately. And it goes down to about 5%. And so the sensory nerves are really important for relaxing those back and allowing the rest and digest state to keep going. I think there might be, our data suggests that there's some deficiencies in the sympathetic side as well, but more people are looking at the sympathetic nerves just across a number of conditions, and that's not our focus, and that appears to be preserved a little bit better. But I do think that it is important for preserving digestion. And I didn't get into a lot of the anatomy, but sensory nerves do what they call axo-axonal control. So in addition, they send messages in both directions. So they can also sense different conditions, pH, things like that in the gut, and activate, for that reason, bring more blood flow in. And so ideally, you can be responding to inflammation with an increased vasodilation, bring more blood flow to help clear that out. And that's clearly not something that's happening based on the literature in the gut wall itself, or based on our experiments in the mesenteric artery. So I think there's a lot of reasons that that's probably true.
Okay, final question. How does chow play a role in these studies? Would a Western diet exacerbate markers of IBD or perivascular dysfunction? So
we have never used anything but standard chow in these animals. I'm not sure if you put them, I'm guessing they probably wouldn't tolerate a high fat diet very well just because of all their GI inflammation, but I can't say how it would affect the actual physiology of the blood vessels. As I was saying, based on Jaume's question, I think that there's a lot of parallels between what we see and what people see who are studying similar phenomenon in obesity, but I just am not sure how relevant it would be to IBD to repeat those experiments in a high-fat diet, because that's just not something that you would ever recommend a person with IBD do. The Western diet, if you look at the prevalence of IBD throughout the world, people who are eating a Western diet are much more likely to have IBD. So in that sense, yes, it's certainly contributing. And I would expect that continuing on a Western diet would only exacerbate the problem, or perhaps speed up the pathogenesis of the disease.
Okay, great. Thank you very much, Dr. Boerman. It's a great talk.
All right. I'm over on the 4th floor in MPP if anyone wants to stop by anytime.
Thank you. That was fantastic.
You're welcome.
Thank you, Erika. That was great.
Thanks.
Thank you, Dr. Boerman.
That was great.